So the last topic we are discussing about the fracture, orbital ethmoid fracture, or is called NOE fracture. There are other names for the NOE fracture: fracture of the ethmoid, nasal orbital fracture, nasal ethmoid injuries, orbital ethmoid, like that. Topic: the learning outcomes to identify what type of a fracture and what are the basic principles to manage the fracture. First of all, we go for the anatomy of nose. Mesoorbital ethmoid is situated in the central upper midface. You can also triangular frame. The bone consists of that four cavities include like a cranium, orbits, nasal and maxilla. Four bones are like paired nasal bones, frontal parts of the maxilla, ethmoids, and lacrimal bones. And perpendicular cruciform plate of ethmoid, nasal parts of the frontal bone, spinal bone. So the main strength by the vertical buttress and the horizontal buttress, and the nasal bone contains, you already know about the maxillary sinus. The contains that maxillary sinus would be there, frontal sinus, superior middle and inferior meatus, spinal sinus, like that. So the main significance what we are telling you about will be main significance. The ethmoid is the high middle wall of explosion, places orbital apex of the orbital canal at the risk. So first we go for the breast plexus. It's a breast plexus called the little area. Little area is an anti-inferior part of the nasal septum where the four arteries that anasmos, that is the plexus. So the four arteries will be there: anterior ethmoidal artery, sphenoparietal artery, greater parietal artery, and septal branch of the superior labial artery. So these are going to one of the become the plexus, and there will be chances of the bleeding from this. So what will happen? That is called little stereo or little plexus. So the anti-ethmoidal, post-ethmoidal, and sphenoparietal artery and superior labial, and the fusion that is called fusion the plexus that called the plexus or little area. So the bleeding starts from if there will be any injury to the particular area, then there will be bleeding, or there will be high pressure variation, there will be chance of the bleeding from that area. So how you manage that epistasis from that area? Either we can use the pack or using with the chemical cauterization. Using with the pack means applying the gauze pack by a layer, the pack inside the particular, so we can apply pressure on that particular point. So multiple layer of gauze piece will pack on carbon gauze, or gauze pack will apply on that area. Otherwise we can use with the chemical cauterization. So the nasal, they are classified into the three layers that according to the vertical lines. So the first one, the level one, the injuries do not extend beyond the line of the lower end of the nasal pods and the anti-nasal pine. So the cartilage will be mostly intact and the nasal pine very little bit. The level 2, no, the injuries are limited and the external nose and do not touch the orbital rim. So the orbital rim will be free from injury. Level 3, the injuries are more serious in the orbital and because of intracranial structures. So these are the three levels of fracture we can see in the nasoorbital injury. There are a lot of classifications are there, Rowan Williams, Flanagan, Robertson, and ellipse classification like that. So, how will you uh, pack the nasal bone fracture and the POP plaster of Paris cast? How will you reduce the fracture segment also? A plaster of nasal pain beginning give it to the patient by the reduction of nasal bone injury. You can see in the picture there are instruments using called the Balsham forceps and the dry plaster band is shape of a T. We can place it on the frontal bone and the nasal part. So we can place to prevent the plaster entering the also. We can reduce the stabilize the fracture segment. So the injuries happening on the nasal bone, the lateral side, the anterior part, and a crush injury. When the force is acting on the lateral side, there will be the multiple fracture segments of the nasal bones, and also there will be nasal septal damage will be there. So if we keeping on the mostly on the rotaries and the each is going to directly hit to the nasal, so there will be multiple fracture segments of the nasal bone. So all these things we can see it in the radiograph. If you're going to take a lateral nasal view, you can see there will be multiple fracture segments. We can notice on the radiograph. Mostly they are taking for a CT or a 3D CT X-rays. They are taking off. Then only we can identify the fracture segment. So, what are the instruments used for the reduction of nasal bone fracture? There are the two instruments used for the fractures in English: Wilson forces and the anti-septal forces. Wilson is showing the picture A, that is Wilson and the anti-septal the C. So there will be sleeve on the one beak, so it will touch to the soft tissue and it will go inside the nasal cavity. These are the four forces. You can see in the picture that how the Balsam septal and Balsam forces are using that the sleeve part they will uh, adapt it to the external side of the nose and the other part will go inside, so we can reduce the fracture segments. Either we can apply the force anteriorly or laterally, then we can reduce the deviated nasal septum. Also we can and also we can reduce the anterior nasal spine, everything using the actually septal. So what we'll do after that, we can pack that area using the carbon cause at around 2.5 centimeter total force is back to the inside the nasal cavity. So before that we will soak with the bismuth aerofin paraffin paste, then pack it inside the nasal cavity to reduce the infection. Suppose if you leave more than 2 days, there will be chance of infection will be there. And the oldest techniques they are using is stainless steel splint will be used to reduce the fracture segment to stabilize the, you can see on the picture the pin will support the anterior nasal spine. These are the oldest techniques we use. You can see in the radiograph how they use the nasal contracting things. So area orbital command fracture is in the upper central complete phase and fills the nose orbit, maxilla and the cranium. And the intraorbital space is situated between the orbits and beneath the floor of anterior cranial fossa. So the intraorbital space is too fragile and near the labyrinth, bisected by the perpendicular plate of the ethmoid and the nasal septum. And there will be lateral extension, thin medial orbital wall, posteriorly sphenoid bone, anteriorly nasal ethmoid orbital abutment. So the surgical anatomy regarding the nasoorbital fracture mainly the middle we already know the medial canthal ligaments are situated inside the orbital. So what's the anatomy of the mid-canthal ligament? Now there will be provides the medial support and function to keep the eyelid stagnant to the draw, and also individually associated with the lacrimal drainage system. So the turbulence finds out into the lateral surface of the nasal bone, posterior matters the lacrimal fossa. Superior limb hosts the lacrimal sac, joins the function of the frontal fossa of the nasal within the of the frontal bone. Fracture pattern is a unilateral bilateral simple locomotor and isolated to the central midface, adjacent to the other facial structures such as the frontal orbit and the maxilla. Mostly the NOE fracture that are associated mostly with the frontal one will be there, orbital and the maxillary bone will be there. So the person is isolated bilateral, isolated unilateral, bilateral, unilateral. Yes, I already told you there will be type 1, type 2, type 3 fractures there. There are a lot of classifications. So the clinical features NOE fracture localized and at the nasal periorbital region, periorbital and some congenital hemorrhage, base laceration of the forehead and the nose, and laceration overlying the middle and canthal tendon impedes the lacrimal system reception. There will be lacrimal reception will be there. Subcongenital hemorrhage will be there. There are a lot of laceration may be noticed in this type of NOE fracture. And the dismissal of the entire nasal pyramid posteriorly and inferiorly, flattening of the nasal dorsum, and compensatory increase in the nasal width, elevation of the nasal tip. Nasal septum is buccal beneath the collapse and the nasal dorsum, and thickening of the boggy mucosa. So there will be edematous on the nasal area. Nasal septum also will be deviated. There will be ecchymosis. Everything we can notice in the patient. And also we can notice there will be diplopid evolution will be telecanthus will be there. These are the most clinical features we can see in the fracture. Chromatic telecanthus, that's very important. It is increased intercanthal distance between initially obscured by the local edema. The medial canthal ligament and its attachment to the anterior lacrimal crest become laterally displaced, and palpebral fissure is narrowed and almond shaped. Medial angle blunted obliteration to the concave. So how will you find out the normal intercanthal distance by males 33 to 34 mm, females 32 to 33 mm? So what it is more than above 35 mm is abnormal. So measure intercanthal distance. Normally it is very difficult for the patients. How the normal value? So interpupillary distance and divided by 2, that's the intercanthal distance of that patient. So any fracture can be accompanied by the fracture of the anticranial fossa resulting by the dural tears and pseudocephalus cerebrospinal fluid rhinorrhea. That is means CSF rhinorrhea. CSF rhinorrhea, how will you examine? That is very important because uh, most of the time there will be NOE fracture and the LIFO2 or LIFO3 fracture. How will you identify the CSF rhinorrhea? So there will be salty taste and handkerchief. There will be mucosine stiffer linen on the drain, but CSF leaks keeps on soft uh, and a halo sign, double ring sign. These are the mainly seen CSF rhinorrhea. And also we can see called a tramp line effect. It occurs when the CSF mixed with the blood. So it appears like yellowish discharge and mixes with the blood. That so it's contain a high protein content will be there. More viscous CSF forms. Central attack with the blood on the either side with the diffused to the edge. So, what are the laboratory diagnoses noticed on the CSF rhinorrhea is glucose test, that is less than 30 milligram per deciliter, protein analysis, beta transferrin test, and beta trace protein, and electronic nose. These are the mostly glucose test, beta transferrin, and beta trace protein analysis. These are the commonly used tests for the CSF rhinorrhea, and olfactory senses will be compromised. So going for the radiology assessment is the oxidative frontal view. That means CBCT, 3D CT like that. We will go and intercanthal fluorescein MRI will take, because the PCS of rhino there will be high chances of meningitis will be there. So the surgical management, what will do the identification of the extent and the type of fracture pattern, and there will be early surgical exploration and meticulous anatomic bone fixation, because there will be multiple fracture segments will be there, so it is very difficult to manipulate. Specific attention to the nasal-orbital soft tissue reconstruction, because it is very fragile, so it is very difficult to manipulate and reconstruct the orbital reconstruction and the nasal bone. So the surgical exposure, the surgical approaches for the NOE fracture is coronal incision. By coronal incision from the one side to other side, means mostly incision start from the preauricular region to the other side of the preauricular region. So we can reflect and we can because NOE fracture there will be the, I already mentioned, there will be frontal bone fracture will be there, maxillary bone. So we want to declove and we want to reduce the frontal bone and the nasal bone, ethmoid bone, everything. Then we'll go for low eyelid subciliary skin muscle flap, maxillary gingival sulcus incision, burst laceration of the nose or the front, because there will be laceration on the front face or nose region, so you can approach with the laceration. Low organization like a horizontally around the open sky incision or the vertical nasal midline incision. So these are the incision, transconjunctival incision and canthal incision we are placed lower the eyelid. Bicoronal incision, it is called bicoronal declaving the face. Then the through the laceration, H-shape incision, bilateral set, midline vertical incision, W-shape, and the bicoronal incisions. Techniques of the repair is the frontal bone. The frontal bone means the frontal process of the maxillary bone to the frontal bone, nasal bone to the frontal bone. Means you want to reduce uh, for the fracture, because there will be frontal bone fracture will be there, then maxillary bone fracture will be there, frontal process of the maxilla, nasal bone, everything. So in the middle canthus, there will be a repair of the middle canthus. There will be, because there will be nasal bone fracture. No, the middle side of the nasal bone also will be fractured. So we want to reduce with the mini plates. Otherwise, there will be diplopia will be there. Otherwise, we can fix the middle canal ligament to the opposite side of the orbit. Using the picture, there will be multiple fracture and using with the mini plates, forward with the gap or G-shape, three-dimensional plates, and the erection of the middle canthus. Next one is the orbital blowout fracture. There are two types: blow-in and blowout fracture. Blowout fracture, the is called pyramidal or conical, and apex the optic foramen, middle will be the lamina papilla, floor with the extremely thin, separates antrum and the orbit, transits infraorbital nerve. Because orbital blowout fracture means the contents of the orbit uh, gone, means the contents of the go through the maxillary sinus. If the blow in means the contents the pushing inside the orbit. So you can see inside the orbit there are a lot of bonds are there. Zygomatic bond, attached to zygomatic bond, maxillary bond, palatal bond. Palatal bond is a yellowish bone we can see between the ethmoid and the maxillary bone, lacrimal bone, nasal bone, then superior orbital fissure, infraorbital fissure, sphenoid, like that. So fracture of the floor of the orbit, the globe is incompressible, and objects taking the globe cause a rapid rise of the intraorbital pressure. There will be a rising in the intraorbital pressure. The orbital floor fractures and it's weak because the floor of orbit is very thin. So the fracture will be there in the floor of the orbit, and the condenser of the orbit going towards the maxillary sinus. So that is called a blowout fracture. If the condenser of the sinus or the floor of the orbit going towards the eyeball, that means blow-in fracture. So mostly blowout region there will be direct injury to the orbit. Now there will be inter orbital pressure and the condenser. You can see on the floor of the orbit, the condenser of the orbit towards the maxillary sinus. So periorbital fat herniates throughout the defect and inclination or tethering of the inferior oblique and the inferior rectus muscle or sharpening arms of the fractured bone. So the clinical features we can notice in the broad fracture: circumorbital edema, ecchymosis, circumgenital ecchymosis, surgical emphysema from the antrum, ophthalmos and exophthalmos, position the diffusion of the intraorbital. The clinical features means the diagnostic upward and outward rotation of the eye not possible. It is very difficult to move the eye, and diplomacy when I attempt to the gaze upward and outward motion, and secure the gestures that the ophthalmologist will do. Edema also restricts the globe of the movement because there will be edematous. You can see after the fracture. And also we can go for the force reduction therefore you can see in the picture the contents of the orbit in the CT. You can see the contents of the orbit going to the sinus, and you can see the ocular level will be disturbed compared to the right eye because the herniation of the contents towards the maxillary sinus, such the ocular level become lower. The clinical test is the force reduction test. Force reduction is nothing but refer the eyelids and apply the topical LA on the lower eyelid region, and using a uh, blunt injection like some tissue holding forces, and then pull the inferior rectus muscles and ask the patient to look for upward. No? So you can see the movement of the muscle is not freely movable. So that means entrapment of the muscles in the fracture. You can see in the maxillary floor of the maxillary. Sorry, floor of the orbit. You can see there are multiple fractures. The muscle will be entrapped. So we are to do using with the force reduction test. Radiology of the isolated blood fracture of the orbit now will be, you can see on the CTG of the CT or OPG laser, now we can see the hanging top of mostly on the 3D CT or say CT. Then haziness and the hanging top appearance seen only on the blowout fracture. And haziness and opacity of the advancement of the damage of the zygomatic complex of the or zygomatic arch. Tomography to demonstrate the extent means if we go for a 3D CT then only we can show how much extent the fraction will be. And computerized tomography to demonstrate the muscles. So then only we can understand where the extent of the fracture might be. Mostly in the nasal orbital ethmoid fracture the extent will be more. because there will be leaf 3 fracture, leaf 2 fracture will be there, leaf 3 plus the frontal bone fracture will be there. So there are multiple bone fracture will be in the nasal orbital fracture. Next, and when in CVCT, you can see the hanging drop appearance and condition of the fat contents towards the maxillary sinus. And all this thing happened, then the most important way how we can reconstruct the orbital content in normal position. It is it is little difficult because the orbital reconstruction we can never use with the place because the bone is very thin, so we can never fix it easily. So normally they are using with the titanium mesh. It is a net type of titanium material or SS material that you can see in the first picture. They use as a net. So what they will do first, you want to pull all the herniation. Sorry, the pull all the fat contents towards the orbit. So we'll put a Foley's catheter inside the maxillary sinus and inflate. So all the contents that will pull back to the orbit. Then we will uh, reconstruct it using with the titanium mesh through the transconjunctival approach or other approach. Mostly the transconjunctival approach, so there will be laceration will be less. So using with the titanium mesh and we can reconstruct the floor of the orbit. So the indication mainly for the surgery is diplopia even 14 years after admission into the matter more than 50% of the content of the orbital body is at discharge, lobe retraction or restriction on the upward movement, and anophthalmos is below 3 mm. Lower eyelid and infraorbital access. These are the but ideally is transconjunctival approach, so there will be no any laceration we can seen after the surgery. This is the transconjunctival approach for the lower retract the lower eyelid and the incision is placed uh, and incision place and we can identify the floor of the orbit and we want to reconstruct using with the titanium mesh with the screws and the materials. Sometimes if you don't have the mesh, then you can use the graft materials. There are autogenous graft and the alloplast. Autogenous means a clavarial bone graft. Alloplast like prolink mesh, porous polyethylene titanium mesh, elastic and the polygalactic. These are the materials used for the reconstruct the orbital flow. The mesh also will be there. It's very thin. Orbital for using in the graph, the clavarian bone will take it out. No, you can see on the picture the clavarian bone and to replace using the orbital floor reconstruction is the old technique, but now everybody is using with the titanium mesh or silicone maybe like that. But after this, what are the main complications we can see? There will be a retrobulbar hemorrhage that will lead to blindness. Superior orbital fissure syndrome and subprotosis, edema, fixed direct people, diminished light reflex, loss of corneal reflex, loss of sensation in the forehead, everything. And our orbital apex syndrome, similar to the supraorbital fissure syndrome, but can cause blindness because of the involvement of the optic nerve. These are the complications we can notice in the nasoorbital uh, fissure. So, I am giving a brief summarize this thing. First one is the nasal orbital. What are the clinical features? Before that, what are the classification? What are the clinical features? How will you identify the nasal orbital fracture? And I think we can see in the nasal orbital fracture. What are the like CSF rhinorrhea? What type of test we are going for a CSF? What are the things we will do it? That is very important. CSF leak, that glucose test, beta transferrin test like that. And how can we reconstruct the orbit? That is very important. What can be blowout fracture? That is very important. How we can reconstruct the blowout fracture? What are the materials we can use? These are the main things in the nasal orbital fracture. Thank you.